You mentioned in your report as one of your deviations from the you stated in your report, in fact, in referring to lorazepam and midazolam, they're not even considered as part of off-label armamentarium of medications for refractory insomnia. Why were you mentioning refractory insomnia in your report?
I was just trying to make a point that it is just so outside the realm of standard practice.
What is refractory insomnia?
One that does not respond to standard therapies. And like we discussed yesterday, standard therapies begin with behavioral and cognitive approaches and looking for secondary causes first and eliminating them, dealing with those underlying problems, and then getting into the medication management.
So when you eliminate the secondary causes, then do you determine then it would be primary insomnia?
If the patient is still having symptoms, you've eliminated all secondary, you've done a very thorough workup as we've discussed, then that is the most likely case that it is primary. That's correct.
And once you determine that it's primary and the patient doesn't respond to your normal treatment that you would for primary, then you would determine that it was refractory. Is that correct?
Depends on what therapy. I mean, you have to give a patient a chance, and you have to go through the appropriate behavioral modifications that we talked about. You cannot just go directly to medical management and giving pharmaceutical agents to patients.
Am I correct in assuming that you've also read the records of Dr. Murray dating back to 2006, 2007, 2008?
In reference to?
Treatment of Michael Jackson.
There were some scattered minimal records that I did review, yes.
And you saw in those records where he had used other drugs such as Restoril?
I did see that, yes.
And you also probably saw from the reports there was other sleep medications present in the house of Michael Jackson, prescribed by other doctors.
I did see that.
And in the event that none of these, and so you did see that the insomnia dated back a long time, way before 2009. Is that correct?
There seemed to be a problem with that based, we're basing that not on any kind of record saying that this insomnia has been worked up, what kind of insomnia it is. We're just inferring that by the fact that he was receiving medications that are traditionally used to treat insomnia.
Now, he had several doctors, to your knowledge, prescribe treatment for insomnia. Is that correct?
Yes.
Dr. Metzger? Dr. Klein?
That's correct.
Dr. Adams?
I don't recall.
Assumes facts not in evidence, and
I'm asking him a question.
I will rule the objection.
I don't recall that last name.
And would it be your testimony that if a person has sleeping problems and that those sleeping problems extend for a period of longer than, say, 4 weeks or a reasonable time such as that it would be beyond the standard of care to prescribe sleep medication without doing a sleepiness, I believe you call it a sleepiness test?
it's a testimony
Sleepiness scale? Epworth sleepiness scale?
I'm saying...
Overruled. Did you use that term?
I did use that in one of many factors that I mentioned in the workup of a patient with insomnia. not just a sleepiness scale to assess the degree of the severity of the excessive daytime sleepiness, but also many other factors such as a sleep diary, such as looking for extraneous things, the environment that the patient is sleeping in, looking at other medications that they could be taking, nicotine, alcohol, caffeine. There are a lot of other things, but a sleepiness scale is one of many factors that needed to be looked at.
Okay, so the first thing you'd start with would be the history.
That's correct.
Now, if you ever had a patient that you felt wasn't being forthright in their history,
I'm sorry?
have you ever had a patient that you felt was not being forthright in their history?
Yes.
How do you make that determination?
Well, I try to inquire as much as I can. I try to put every effort in trying to get as much information as possible. And I try to get information from other clinicians or hospitals that have taken care of the patient. So I try to not just always rely on the patient, but if they've been seen by other physicians, other hospitals, I make sure that I obtain all those records as well.
Okay, when you're obtaining those records, you have the patient sign a release,
That's correct.
and if they don't sign the release, you don't get that information, do you?
That's correct.
Because HIPAA doesn't allow you to do that.
That is
correct?
right.
And so if the patient, if you feel that the patient is not being forthright and is not willing to sign a release, what do you do?
Well, there are other parts of the workup that go beyond the history from the patient. Very often, especially in sleep-related disorders, one of the biggest things we rely on is the partner or anybody else that lives with the patient. We ask them, what is going on? Can you just tell us what's happening with the patient? What is their breathing pattern at night? What time do they go to sleep? What time do they wake up? What type of environment do they sleep in? So sometimes we actually have patients that really minimize, and that's very common in medicine, where patients just try to minimize and give little information. So if we have a spouse available who's there or a partner, we try to get as much information from them as well. In addition to that, we do things like the sleep diary we talked about, or the sleep log, where before we do anything else, we have them actually log their sleep pattern for a period of 1 to 2 weeks to see exactly what that sleep-wake cycle is like, when they're going to bed, when they're falling asleep, how many times they're waking up in the middle of the night. So that is imperative as well.
So if a patient reports to you having sleep problems, before you prescribed any medicine, you would get the sleep diary?
That's absolutely one of the...
You'd interview their partner?
Correct.
You would try to do background information, get background information from prior doctors?
If the patient consents, yes.
You wouldn't just give them a prescription of Ambien?
Routinely, no. No.
And would you be of the opinion that any doctor that prescribed, say, 30 Ambien without checking out all these factors that you've suggested here, that would be a deviation from the standard of care?
That is not part of my record. That it would probably not be a significant. People do that in practice. It's not right. I would say it's a very minor deviation of what is right. But certainly that's nothing I've stated in my record about someone using Ambien without having done a appropriate workup or screening.
So it would be okay to use Ambien without the workup?
Unfortunately, this is something that's done, and I don't think it necessarily falls outside the standard of care.
So if I told my doctor that I was having trouble sleeping and he gave me 30 pills of Ambien to take home or get at a drugstore, you'd think that that's probably within the standard of care.
Well, again, your doctor is imperative on him to actually do an appropriate history and try to find out how long the insomnia has been, what are perpetuating factors? What is actually causing potentially the insomnia? What are secondary causes? I mean, the way you're describing it is really not the way it would be done. It would be only after a detailed history. And again, if there is a secondary cause that is apparent right off the bat, that process is dealt with.
And if that secondary cause was an addiction to narcotics, do you generally find that patients tell you about that?
Sustained.
And you also indicate you do a physical examination. Is that correct?
That's correct.
So, and you said yesterday one of the things that can cause insomnia may be an enlarged prostate.
Well, I said that urinary problems that keep patients awake at night, that cause them to have frequency or have to go to the bathroom multiple times can be a factor.
So would you do a prostate exam too?
I wouldn't necessarily do a prostate exam on everybody, but here's the key. You ask about history. That's part of your history that you ask about, is to make sure that they don't have symptoms of prostatic enlargement, because it is, in the appropriate patient, very, very common. In an elderly individual, you want to ask about the urinary stream, you want to ask about frequency, the ability to initiate a stream of urine, but asking about doing prostate exam on everybody with insomnia, no, that's not a part of the routine exam on everybody.
Would you check their arms for needle marks?
Part of the physical exam is a complete inspection of the patient, and really with them putting on a gown, being able to examine their entire body. That is part of the physical exam. And if you do see something abnormal, whether it's a skin abnormality, whether it's a needle mark, a track mark, those are things that you have to document in your physical exam.